Baliga here. This podcast is on call to action to prevent venous thromboembolism in hospitalized patients, a policy statement from the American Heart Association. This document is a publication by the American Heart Association Advocacy Coordinating Committee, and this committee was chaired by Dr. Peter K. Henke, MD, FAHA, from the University of Michigan. It's published in Circulation, 2020, May 7th, Epub, ahead of print. Acute venous thromboembolism comprises of DVT, that's deep vein thrombosis of the legs and pelvis, and PE, that's pulmonary embolism. And it's a frequent complication in hospitalized patients, which leads to increased length of stay and a leading cause of preventable hospital mortality in the US. About 2/3 of the patients with venous thromboembolism present with DVT, and the remaining present with pulmonary embolism as the first manifestation and the primary cause of venous thromboembolism related mortality. It's estimated that the annual incidence in the US in adults is 1 to 2 per 1,000 per year and increases with age from 1 per 10,000 in young adults to 1 per 100 in the elderly. The absolute lifetime risk of venous thromboembolism after 45 years of age is 8.1% overall, 11.5% in blacks, 10.9% in obese individuals, 17.1% among those with factor V Leiden mutation, and 18.2% among blacks with sickle cell trait. This document discusses hospital-acquired VTE, and it's defined as VTE occurring during or within 3 months after hospitalization and accounts for greater than 50% of the population burden of venous thromboembolism in the US. Thromboprophylaxis remains underused or underutilized and misapplied in population studies, and there is no temporal declines in either venous thromboembolism incidence or case fatality. In addition, public and healthcare provider awareness of venous thromboembolism is low and lags behind other common diseases. This document is a call to action to reduce hospital-acquired venous thromboembolism by 20% in the next 10 years, that's by year 2030. The treatment for acute venous thromboembolism is estimated to incur direct medical costs of $12,000 to $15,000 per individual in the first year in survivors. Approximately 18% of patients with venous thromboembolism are readmitted within 30 days at a cost of nearly $10,000 per patient. And between 10 and 30% of acute venous thromboembolism survivors develop recurrent venous thromboembolism within 5 years. Long-term complications following proximal DVT and chronic thromboembolic pulmonary hypertension, CTEPH, 4% CTEPH following pulmonary embolism, contributes to an annual preventable cost of 7 to 10 billion per year from hospital-acquired venous thromboembolism. Common medical illnesses associated with hospital-acquired venous thromboembolism include infection, acute stroke, and inflammatory conditions, example inflammatory bowel disease and autoimmune disorders. Malignancy accounts for 1/5 of the incident venous thromboembolism cases, a 7-fold higher risk as compared to patients without cancer. There is even a higher in select cancer types, for example, brain and pancreatic cancers. Risk of venous thromboembolism in patients hospitalized with cancer have nearly doubled between 1995, that is 3.5% in 1995, to 6.5% in 2012. However, patients hospitalized with cancer are less likely to receive venous thromboembolism prophylaxis than patients hospitalized without cancer. Across all patients with cancer, the risk of venous thromboembolism is elevated up to 7-fold over patients without cancer. In certain subgroups, such as those with pancreatic cancer or primary brain tumors, the risk for venous thromboembolism may be increased up to 28-fold. Overall, rates of provoked venous thromboembolism resulting from surgical procedures account for 20% of all venous thromboembolism. The risk is highest following neurological, orthopedic, oncological, trauma, or emergency surgery. It's estimated to be 2 to 3%. There's a lack of patient awareness of venous thromboembolism and the risks. One large global survey from 2014 reported only half of survey respondents were aware of deep venous thrombosis and pulmonary embolism. This was far lower than other thrombotic conditions, for example, myocardial infarction, 88%, stroke, 85%. Global initiatives, for example, the World Thrombosis Day, reach large audiences but require coordinated efforts across public health, clinical practice, and private sectors to achieve sustainable achievements. There is a kind of health illiteracy regarding venous thromboembolism in the general public. There are several risk assessment models to identify at-risk patients for whom chemoprophylaxis is recommended, including the Caprini, the Rogers, the Padua, and improved scores models. For patients with cancer, the Corona score is utilized to guide chemoprophylaxis. The document says that while most patients receiving chemoprophylaxis do so using a fixed dose, a one-size-fits-all approach evidence suggests that many patients may not receive adequate prophylaxis with this strategy. They recommended using a weight-based approach to improve dosing, particularly for patients with obesity, given that obesity is a risk factor for venous thromboembolism. The role for post-hospital chemoprophylaxis for patients hospitalized for acute medical illness is unclear. While there are 2 FDA-approved medications, rivaroxaban and betrixaban, clinical trial evidence has been mixed, and some guidelines have recommended against routine use in patients without cancer. While numerous risk assessment models for hospital-acquired venous thromboembolism exist, overall use of chemoprophylaxis remains low or inappropriately applied. Some studies have gone on to suggest that only one-half of at-risk patients receive prophylaxis, while other studies show higher use greater than 75%, but also overuse among low-risk patients. Numerous studies have demonstrated the benefit of computer decision support systems to guide venous thromboembolism, chemoprophylaxis orders for hospitalized patients. However, when ordered, greater than 10% of prescribed anticoagulant doses are often not given, reducing the efficacy of this intervention. Common reasons for missed doses include patient and provider level factors. This document recommends venous thromboembolism risk assessment and reporting to be performed for all hospitalized patients, and that this data should be used to benchmark hospitals for comparison and pay for performance programs. This AHA document also supports national tracking of objectively confirmed venous thromboembolism within 90 days of hospitalization. It recommends a central steward of data tracking of venous thromboembolism risk assessment, the use of chemoprophylaxis, and the rates of venous thromboembolism across all hospitals. Table 1 of the document is a summary of 2012 American College of Chest Physicians Guideline Key Recommendation, and these include: for patients with low risk of venous thromboembolism, prophylaxis is not recommended. For patients with high or moderate risk for venous thromboembolism, pharmacological or mechanical prophylaxis is recommended over no prophylaxis. For patients at high risk for bleeding, pharmacological prophylaxis is not recommended. Instead, such patients should receive mechanical prophylaxis, which can be replaced with pharmacological prophylaxis if the risk of venous thromboembolism persists and the risk of bleeding decreases. This table also gives the duration of guideline recommended prophylaxis. In medical patients who should receive pharmacological prophylaxis for 6 to 21 days or until discharge from hospital, whichever comes first. Medical patients should not receive extended prophylaxis beyond the period of patient immobilization or short-term hospital stay. Surgical patients undergoing major surgery should receive pharmacological prophylaxis for 10 to 14 days. The highest risk surgical patients, such as those undergoing abdominal or pelvic surgery for cancer, should receive extended prophylaxis for 4 weeks. Patients undergoing major orthopedic surgery should receive thromboprophylaxis for a minimum of 10 to 14 days, and extended prophylaxis, that is up to 35 days, is suggested for those undergoing major orthopedic surgery. This document also contains nice risk assessment tools and models. Figure 1 is the Caprini risk assessment tool for surgical patients. Table 2 is the Padua risk assessment model for medical patients. Figure 2 is the IMPROVE, or the International Medical Prevention Registry on Venous Thromboembolism scoring. This is, in a nutshell, a very elegant document and a must read to prevent venous thromboembolism in hospitalized patients.